Good afternoon, everybody. Welcome to our first trainee rounds presentations for the T-CAIREM Summer Research Program. My name is Conrad. I am a PhD stream student at the Institute of Health Policy, Management, and Evaluation. And today we'll be hearing from two trainees, Marco Istasy, um, who will be talking about his research in the use of machine learning to identify prognosticators of intracranial metastatic disease in patients with breast or lung cancer. And then in the latter half of today's session, we'll be hearing from Leen Alzebdeh, who will be discussing her work predicting inpatient blood glucose for cardiovascular surgery patients with type 2 diabetes using electronic health records data. So the first presenter is Marco Istasy. He is a fourth-year medical student and researcher at the Temerty Faculty of Medicine, University of Toronto, and an incoming resident in the Division of Neurosurgery at the University of Ottawa. His research interests lie at the intersection of artificial intelligence and medical hardware innovation, with a primary focus on developing technological solutions to optimize clinical outcomes for neurosurgical patients. Most recently, his work was recognized with the Young Investigator Award from the Canadian Brain Tumour Consortium. Over to you, Marco, to begin your presentation.
Awesome. Thank you so much, Conrad, and T-CAIREM for organizing this. I'll start sharing my slides and the obligatory, can everyone see my slides? Perfect. Okay. Again, thank you so much, everyone, for helping organize this. My name is Marco, and it's a pleasure to be able to talk to you about my research in triple machine learning for predicting intracranial metastatic disease in breast and lung cancer primaries. I have no disclosures. To begin with, I think it's helpful to frame the scale of the challenge. Intracranial metastatic disease, or IMD, is a devastating complication which affects nearly 1/5 or 20% of all patients with cancer, metastatic cancer, that is. While IMD can occur across various malignancies, it is overwhelmingly driven by lung and breast cancer. As you can see in the figure, lung cancer alone accounts for 62% of all IMD cases, with breast as a close second, or not so close second, but at 11%. The real urgency with this, however, is that the prognosis without intervention is incredibly narrow, with a median survival time of less than 2 months without intervention, and around 9 months with intervention upon detection. This creates this desperate need for early detection. The difference between detecting IMD symptomatically and detecting it early can extend a patient's survival and quality of life in the order of years. As you can see in these curves, the earlier the metastasis is identified, the significantly higher the probability is for survival. And so really we have this clear golden window, if you will, for detection. And yet, despite knowing that timing is everything, traditional statistical models lack the precision needed to personalize surveillance. We currently are just unable to distinguish between high-risk patients and we don't know which ones will become symptomatic, leaving us rather in a reactive than proactive position. And so given the failure of these traditional models to provide the precision needed in clinical settings, this led to our central hypothesis. We hypothesized that predicting the occurrence of IMD in lung and breast cancer is uniquely suited for the capabilities of machine learning algorithms, which, unlike traditional linear models, can capture complex nonlinear interactions between the feature space or the variables that we study. And so with that in mind, we really set off with two objectives. The first was to derive a machine learning algorithm that can predict IMD while accounting for the competing risk of death. That is, to be clinically valid, the model must distinguish between a patient who is safe from IMD simply because they are low risk and distinguish from one who's safe from IMD simply because they succumb to death or a primary cancer first. And our second aim was to ensure that this model's decision-making process was transparent and interpretable, which ultimately would allow clinicians to understand why a patient is flagged the way they are flagged and facilitate its incorporation into clinical settings. To build these to build these models, we needed data sets with sufficient power to capture the nuances of metastatic spread. We utilize the Ontario Cancer Registry, beginning with screening around over 100,000 breast cancer patients and 66,000 lung cancer patients. And we applied then several exclusion criteria to ensure that we were modeling the right problem. Specifically, we removed patients with multiple primary cancers, prior IMD, or synchronous IMD or non-malignant cancers. And by doing so, we focused our model specifically on metachronous spread, where the spread is actually after the diagnosis of after the primary diagnosis and not on initial diagnosis. And for these patients, we curated a set of clinical features tailored to the biology of each cancer, such as molecular subtypes or histology, while also integrating demographic, socioeconomic, and patient health status variables using the Johns Hopkins ACG system to capture comorbidities. All of this was processed within the secure ICES environment in full compliance with the PHI-PA regulations. And from this cohort, to handle the complexity of competing risks, where a patient, as I mentioned before, might actually pass away before developing brain metastasis from non-cancer or even other cancer-related causes, we implemented a dual-track architecture. We used two separate machine learning Cox models, one to estimate hazards of IMD and the other to estimate the hazard of death. We trained these models using CatBoost, which is a gradient-boosted random forest or decision tree framework. After these two hazards functions were calculated, we joined them into the Allen-Johnson estimator and map these results onto the most clinically relevant time horizons, so 1 year, 3 year, and 5 years to produce a cumulative incidence function. And to ensure that these models were robust and not just overfitting, we employed standard pre-processing techniques such as using a 70-30 split as well as a 5-fold cross-validation. And crucially, to prevent data leakage, all imputation and feature scaling were performed strictly within the cross-validation folds, ensuring that our test set remained entirely independent. The final result of this pipeline is a patient-level absolute risk percentage, or the Allen-Johnson AG cumulative incidence function, CIF, so AG-CIF for short. This is effectively the magic number that will tell a clinician how likely or a specific patient is to develop IMD over the next 1, 3, and 5 years, respectively. And in order to prove that these models worked and were just more than a mathematical exercise, we used a 3-pronged evaluation framework applied entirely to an unseen test data set. So the first prong was discrimination using UNO-C index, which would help us tell if the model could correctly rank patients by risk, so patients who are more likely to develop IMD as opposed to passing away. Secondly, we use predictive accuracy using the area under the precision recall curve. And so in a disease where the event rate is relatively low, such as 3 and 11% respectively, this is far more informative than the standard area under the receiver operating characteristic because it focuses on the precision and the recall. And finally, and perhaps most importantly, we wanted to evaluate the clinical utility of this model using decision curve analyses. In this event, we wanted to know if this tool actually helps clinicians make better decisions in the real world compared to the current state of the care strategy. And to ensure that these results weren't due to chance, we utilized 5,000 bootstrap resamples for our confidence intervals. Now, we'll start the results by characterizing the study population. Having analyzed over around 130,000 patients, our preliminary analysis recapitulated known differences between the two cohorts. First, that the burden of the disease is significantly higher in lung cancer than in breast cancer, 11.2% to 3.1% respectively. And that this carries with it a concordant increase in death. So more strikingly, we see a massive difference in mortality. Around 69% or 68% of patients with lung cancer will actually pass away without having developed IMD, as opposed to 18% of patients with breast cancer. And really, this is why we had to account for the competing risk of death in our models, because over 70% of the lung cancer patients will never end up developing IMD. And finally, we noticed that the timing, there was also a difference. In breast cancer, the median time to IMD was around 2.5 years compared to lung cancer, which was around just less than 1 year, which suggests that this window of opportunity for surveillance is much tighter in lung cancer patients than it is in breast cancer patients. Following, to understand the current state of the risk prediction, we first applied a standard simple Cox regression to the problem to identify the primary drivers of IMD. As expected, the results were clinically coherent and consistent with known biology. So in this figure here, we see that stage confers quite a increased risk for developing IMD, and as well as some molecular and histologic subtypes. The important thing, however, is that when we look at these numbers in context to the cumulative incidence functions on the right, we see that there's a paradox that's being created. A patient can have a very high relative risk of developing the disease, yet still be quite unlikely to develop it in absolute terms. So, for example, if we take a look in the breast cancer cohort, we see that stage 4 confers around a 5 times hazard ratio of developing intracranial metastatic disease. And yet, when we take a look at the cumulative incidence functions separated by stage, in the 5-year time horizon, only around 17% of these patients will actually develop this disease. And so the vast majority of patients will actually be IMD free. And this means that we can't rely on these hazard ratios to trigger surveillance because we will be effectively overscanning around 80% of the high hazard population. And when we rely on these averages, we risk a massive waste of clinical resources and patient anxiety. And really, this is why we needed the ML architecture. And having then moved to this gradient boosted framework, which we described in the methods, we want to see if this actually translated to any tangible improvement in prediction. And the results were actually quite fortunate. As you can see in the comparison on the left, our model significantly outperformed the standard linear Cox models, trained by the exact same architecture, except not using the machine learned or gradient boosted algorithms. And so in breast cancer, we achieved an UNO-C index of 0.95 compared to the baseline model of 0.83. But where this really perhaps shines is in the area under the precision recall curve, which you can see on the right-hand pane. While at the 1-year mark, the precision is modest. As the horizon extends to 3 and 5 years, the curve climbs significantly, reaching around 0.63 for breast and 0.64 for lung cancer, compared to 0.15 and 0.32 for the standard models, respectively. Now, it's also important to note that an area under the precision recall curve that is at chance is actually at the incidence of the disease. So our area under the precision recall curve, if functioning at chance for breast cancer, should actually be only 0.03. And this is really where these models shine, where they demonstrate that they are able to identify high risk windows where intervention would be most effective. Now, while I hope the numbers in the previous slide were impressive, this tool is more than a computational exercise and is really meant to be a tool that's used in the clinic. And to test this, we ended up employing decision curve analyses. So demonstrating both net benefits, which essentially balances the benefit of a true positive classification against the harms of a false positive classification, and net reduction in 100 patients, which demonstrates the avoidable treated patients per 100, and really measures the number of unnecessary interventions that we help with. And as you can see across a wide range of risk thresholds, 0 to 10%, but really our focus was on the 2 to 8%, which we deem to be clinically valid. Our model consistently provides a higher net benefit and a higher net reduction when compared to the standard linear models. Now, to put this in perspective, we translated these probabilities into three clinical risk groups, a low, a medium, and a high risk group. And we calculated the cumulative incidence functions for breast in panel A and lung in panel B. And what we found, which was quite fortunate and quite expected, it was that in the categories of low and medium risk, the cumulative incidence of developing intracranial metastatic disease is low. Whereas the patients which the model identified as high risk ended up having a higher cumulative incidence of developing intracranial metastatic disease. And with that in mind, this would ultimately, allow the clinician to make a definitive decision between low, medium, and high risk patients to help monitor surveillance. Lastly, a common concern with machine learning, especially in medicine and in the incorporation of clinical practice, is that it's a black box approach. Clinicians love to have some epistemic insight into why the model is making the decision it is making. And to that degree, we ended up using combined SHAP values as well as permutation importance to interrogate exactly why the model flags a patient as high risk. And we found that in breast cancer and lung cancer, the identified variables align with established oncologic predictors. So, for instance, in breast cancer, stage is a dominant driver. And if you recall, this actually was the highest driver in the linear Cox model. And then we also see that certain subtypes confer an increased risk of intracranial metastatic disease, such as triple negative and HER2 positive, which is something that we also see in the Cox models. In lung cancer, this was the same thing with stage, histology, as well as tumor size. And so ultimately, now we have the models, but so what is the real question. And how does this change the way that we care for patients? Currently, we're caught in this dilemma, really, where either we image everyone, and it's a massive waste of clinical resources, which, to be honest, we aren't at the stage to perform. And we also add risk and anxiety for patients, or we just wait for neurologic symptoms to develop. And as we saw earlier, this means catching the disease quite late and having a shortened overall survival. Our model hopes to provide this third way in which we have this personalized risk score, which can, from that, end up developing a surveillance program that's patient-specific based on their risk score. Of course, it's important to acknowledge the limitations of the study. First, we did use retrospective administrative data set from the Ontario Cancer Registry. While this provided an immense cohort, it naturally lacks granular data. Specifically with the lung cancer cohort, we didn't have any specific molecular drivers like EGFR or ALK, which are known to increase the risk of metastasis. Furthermore, the study spans around 13 years, so there is temporal drift and differences in treatment dynamics. Specifically, there was a lot of immunotherapy that was pioneered within this past decade. And finally, because the study was limited to a single province, the results really do lack in overall generalizability to different provinces and perhaps different patient demographics. But to conclude, I just want to leave you with three key takeaways. The first is that we've shown that this machine learning can fundamentally outperform traditional linear models and provide a level of discrimination that was previously, really unattainable with traditional statistical models. And more than being a computational exercise, this has direct clinical utility in that we can improve precision, we can move away from either a treat all or a treat none approach, and significantly reduce the burden of unnecessary imaging without compromising patient safety. And third, that we did these two things in a biologically transparent manner, which is critical for helping with, helping clinicians trust this tool and ultimately having it incorporate into the clinical practice. And ultimately, it's our goal that this work moves us closer to a proactive surveillance paradigm where the right patient can get the right scan at the right time. These are my acknowledgements. Huge shout out to all of these individuals who helped make this work in reality. My references, and this is our recently published paper for those who are interested in learning more about the study. Thank you all for listening.
Wonderful. Thank you, Marco, for the presentation. Very interesting work which you're doing. Now we will be having some questions. We'll start with the adjudicators here at T-CAIREM, and then we'll open up the floor if there's any time left for the audience to ask questions. I wanted to check in with Alex if you had any questions. Otherwise, happy to ask a question first.
Yeah, no, I have a couple questions. I don't know if you want to alternate or we'll
No
we'll
worries.
figure it out. Marco,
Anything
thank you
works.
for the
No.
presentation. It was very clear. Nicely done. Can you talk about the you mentioned this dual branch architecture that you used to predict the different risks. Can you talk about like how you got to that point? Did you try, a single branch or was there a particular reason why you did the dual branch architecture from the very beginning?
Yeah, of course. I mean, I think as we worked on this project, this was to be very honest with you, this was my very first survival analysis. I come from problems which are categorical in nature, which obviously employ very different architectural paradigms. So when we were reviewing with some of our statisticians who were helping with the project, particularly Dr. Amol Verma, he had suggested that the standard in this case would be to have this dual-pronged architecture to calculate both hazards individually for both death and IMD, and then to use the Alan Johnson estimator to combine them into a single cumulative incidence function. So I can't say we tried a single track architecture to assess for the competing risk of death.
Okay. Did you by any chance do any comparison across the two branches? Like, was there anything like similar? Because you have like the interpretability results. I assume at the end. Did you do some of the intermediate stuff?
We did, yeah. Sorry, I didn't show them in this slide, just in the interest of time. But for both the Cox models, actually we can see them here for the machine learning models,
Mhm.
where the dark bars are the machine learning SHAP values for IMD, and then or sorry, not the SHAP value, the rank importance of IMD, and then in the slightly more transparent is actually the rank importance for death.
Gotcha. Okay. Interesting.
And so we carry that out. And so, initially one thing that we'll note is one of the things that's quite important is actually age at diagnosis.
Mhm.
Right? And that makes sense because if are diagnosed at a younger age, you actually just have a longer time to be able to develop
Mhm.
IMD, whereas if you're diagnosed quite later on, you're likely to succumb to death before you are to IMD.
Okay. Interesting. Last question, and I'll let other people. You mentioned very briefly a linear baseline, and I might have missed the slide where you described that. Can you talk about how that baseline was formed?
Of course. So the perhaps it's best to go to the architecture slide here. And so this was our current architecture where we have the cause-specific hazard models. So we use the CAT Boost Cox Model 1, which estimates IMD, and then the CAT Boost Cox Model 2, which estimates death. And these are both gradient boosted decision forest models. The linear baseline did weigh with the CAT Boost part of things, and so we just trained two Cox models as opposed to using gradient boosted approach.
Okay, so it's replacing the architecture, but still doing the dual branch
Ex-
combination. Okay, got
Exactly. It's the exact same thing, exact same metrics, exact same pre-processing. It's just replacing the gradient boosted part with a linear part.
it. Okay, cool. I have one more question, but I'll throw it to other people to give them the chance. Thank you.
I guess I had a quick question in regards to the stage variable. So it seemed to have a very high contribution to your model's performance based on the SHAP analysis. I was wondering if your team kind of was or like was there any concerns around the residual label leakage in this like for this variable, or maybe was there some indication from literature, people including the stage values? I was just curious if there's any kind of risk of label leakage for that variable.
Yeah, I mean the reason that label is so high is to be honest just biological coherence. Stage 4 by definition is metastatic. And so the way cancer evolves is, or at least solid tumors evolve is at first locally, and then through hematologenous seeding, they can spread to different areas. Once they spread to any other area than the primary site, it becomes stage 4. And so by definition, stage 4 is metastatic. It's just not metastatic to the brain. But we expect that to have, such a strong contribution to the development of intracranial metastatic disease.
Wonderful. Thank you so much. I think we have time for perhaps two or three questions. Um, if folks have any questions in the audience, you're welcome to raise your hand and ask a question. If not, we'll go back to Alex.
Giving people a chance in case. Oh yeah, go ahead.
Hi there. Thank you so much for the talk. I just had a question, and forgive me if this is a naive question, but what was your reasoning behind picking the cat boost machine learning algorithm as opposed to XGBoost or like other machine learning algorithms?
Yeah, I mean, thanks so much for the question. And to be honest with you, Cat Boost natively handles categorical features. That's what the cat in the boost is for. And so it just helps us, there was XG Boost, there was Light Boost, and all these other algorithms. Cat Boost was the one that handled best our categorical features and allowed us to maintain some level of interpretability throughout every step of the process. And so we ultimately ended up deciding with Cat Boost.
Thank you.
Thank you.
Any other questions from the crowd before I pepper them with one more? Okay, I'll ask one more. So you mentioned this is the first time that you've done the risk modeling before, and truthfully, even as a computer scientist, I don't do a lot of risk modeling. I tend to do regression and classification, these kinds of things. So my question might even be a little naive here. You talked about how you're using the model to generate a risk score when it's all said and done. But then a lot of the analyses that you showed were based on classification. So can you just talk through how you reconcile that? Like, were you using the models for both classification and risk scoring, or were you doing rounding of the risk scores? How did you get from one to the other?
Sorry, by classification, do you mean like in this
Like you're reporting
like
a
in this
precision
figure?
curve. Well, even before you're talking about AUP, RC, and all these yeah, recall, sensitivity, specificity. So that's assuming some sort of classification task. Um, but it sounds like the models you're focusing on. I mean, you're often talking about generating a risk score, but I guess somewhere in that pipeline, you're making a binary decision of, yes or no, or positive or negative.
Yeah, over the I mean over the specific time horizons that we had. So the AJCIF, which is the Allen Johnson cumulative incidence function, does we did threshold it at around 60%.
Okay.
At the end of the day. And so any patient who was high risk as per the Allen Johnson in this specific analysis was deemed to have likely to be able to develop the intracranial metastatic disease. And that was compared to the ground truth data.
Okay.
And then for here, we actually didn't use a binary threshold, but we used three different risks. So in the low risk is less than 5%, medium is 5 to 10%, and high risk is greater than 10%, as per the AJCIF for developing this disease.
Okay, cool. That's all I was looking for. Thank you.
Thank you, Marco. Our next presenter is Leen Alzebdeh. Leen is a graduate student researcher at the University of Alberta. She's developing predictive machine learning models to predict blood glucose in hospitalized patients using electronic health records, with the goal of alerting staff to upcoming dysglycemia and enabling timely, personalized clinical decision support. Her work aims to further automate insulin decision support, thereby reducing demand on healthcare staff, lowering hospital expenses, and improving patient outcomes. Over to Lean to begin your presentation.
Thank you so much. Thank you for being here, and thank you so much for having me. I hope you can see my slides and everything. Okay, sounds good. So my name is Leen. My supervisor is Dr. Anna Lam from the Department of Endocrinology. My background is in computing science mainly. I'll be presenting our project, predicting patient blood glucose for cardiovascular surgery patients with type 2 diabetes using electronic health record data. This is just the outline. So we probably know that blood glucose too high or too low can be quite harmful, but for hospitalized patients, it can worsen outcomes. It can increase complications, length of stay, infection risk, and even mortality for surgical patients sometimes. The problem, however, is you typically administer insulin in the hospital for controlling hyperglycemia, but finding the right balance without risking hypoglycemia, blood glucose too low, is the difficulty with controlling blood glucose. And in fact, on average, 30% of inpatients experience extreme blood glucose during their stay. So it remains an issue. The motivation is that research has shown that there are specialized dedicated diabetes teams, like diabetes nurses and such, that can help improve outcomes, but they're often too expensive, too inaccessible, or too overwhelmed, depending on the hospital or where the hospital is. So our proposal is to create a sort of machine learning, more scalable, more cost-effective alternative that can help augment decisions. So our proposal is to engineer a blood glucose prediction model that alerts healthcare staff of the upcoming extreme glucose values. And there are different ways that we would actually incorporate it in real life. We're still thinking about the actual how it would work in real life and how we would make it work. But this is one example of how it works. So you have a patient, it's lunch. You have the electronic health record system that's integrated with a blood glucose predictor. You would take the patient's measurement, it's 9 millimoles per liter at lunch, and you would input it to the system. You could input the intended insulin the insulin that you intend to give, 1 unit, let's say. And then it tells you what it projects for supper, because typically it's taken, at least in our case, 4 times a day. And it tells you it's going to be too high at 15 millimoles per liter. So the staff makes a decision and they say, what if we give 2? And then it projects a normal level of 7 millimoles per liter. So that is one example of how it would work in real life. Most of the research on blood glucose prediction focuses on short range because most of the research uses continuous glucose monitors, which typically sample measurements every 5 to 15 minutes. This is an easier task, so the errors are much lower because you're only predicting at most half an hour ahead usually. However, CGMs are more expensive and they're more uncommon in hospitals, and it would not fit as easily with existing workflows. As a result of the CGM focus, there's a rare focus on capillary blood glucose, typically how blood glucose is taken for most hospitalized patients. And of course, a rare focus on electronic health records data because, again, CGMs. And yeah, again, because of CGMs, most of the research is done in ambulatory type 1 diabetes or type 1 diabetes in general, and there's a rare focus on type 2. So our research is at the intersection of all these 3 gaps, and as far as we know, it's the first to do all 3. And the project mission in detail is to predict routine capillary blood glucose measurements. In this case, it's 3 pre-meal ones, breakfast, lunch, and supper, and 1 bedtime, in hospitalized patients with type 2 diabetes using electronic health record data. And the downstream task is to actually automate the insulin part. So instead of having to input the insulin value, we could tell you, like the model could tell you the ideal insulin value, or it could say, or the nurse could input what insulin value they want to give, and the model would adjust within a certain range just to make it safer. But yeah, that would be our next stage of the project. So yeah, the blood glucose predictor could be used as a foundation for insulin because they're very related. Just quickly on the related works, most of the research, like I said, has been done in CGM, so that's the top 2. And the bottom, they've done it on ICU patients. It's a different population. It's also a shorter range of 2 hours. And they achieved a Clark error of 97%. Clark error will be more relevant later, but it measures what percentage of the predictions fall within the target range. So it splits it into zones. We want to be in zone A and zone B. So this means that 97% of their measurements fell within zone A and zone B. And there was also another study using capillary blood glucose data at slightly shorter intervals and also at a different population. Most of their population was not type 2 diabetics. For our methodology, our data set it's a retrospective cohort from the Bzykowski Heart Institute between November 2019 and April 2024. We started out with 7,000 patients. We only included adults who've had surgery and type 2 diabetes. We also excluded hemodialysis, pancreatectomy, parenteral nutrition, insulin pump, dialysis, and stay, because all of these alter glucose dynamics. We also excluded missing or wrong height. And we also, after all the pre-processing, we dropped any patients with less than 5 blood glucose measurements, just because we wanted to give the model time to predict. We ended up with 1,279 patients and 37,906 measurements. The number of features we ended up with in 38 feature categories. So blood glucose, patient demographics like age, weight, the pre-admission A1C, visit information, it could be labs, procedures, medications, etc. For the pre-processing of the blood glucose itself, we dropped, those like a few erroneous measurements. We also dropped any measurements taken during IV insulin and enteral nutrition. The same reason is because it alters glucose dynamics. We hope with more data that we can expand it so it's more generalizable, but because the data is so limited, we wanted to make the model kind of not confused. And because we dropped these measurements, there was some gaps in the encounter, so each encounter was split into different series. And we imputed any missing measurements within that series. And if there was multiple measurements within one interval, we picked the one right before subcutaneous insulin injection or the earliest in the interval, just to reflect the pre-meal state. We also dropped overnight measurements, and we anchored each time series to breakfast. So this is how we turned the sparse irregular electronic health record data into structured data. For pre-processing, if we had multiple categorical measurements, let's say, was insulin taken, yes or no? Yes would be 1, so we're hot encoding as well. 0 would be no. If there was multiple of those, we just recorded at once. And we also mapped medications to ATC and diagnosis to ICD-10. Our population, our data set is predominantly male. The median age is 67, pre-admission A1C is 7.4, spent about 8.6 days in the hospital, and about 12% of their blood glucose was missing for each patient. The blood glucose median was 8.8. This is all the patient's measurements mapped onto the first, I think, 6 days here. So you can, the red here bolded is the average over those 6 days. As you can see, it's somewhat elevated as we would expect. This is a quick example of how it works. So you have a look back window of 4 measurements. It could be up to 6 days. And we're predicting here the first measurement in the interval and discarding the second one. Here, this is breakfast. And now we take breakfast, and now the look back window is increased to 5 measurements, and we're predicting lunch, the one right before the subcutaneous insulin. For models, we used basic machine learning models like ridge regression, stochastic gradient descent, and XGBoost. We also tried using deep learning models like TCN, temporal convolutional networks, and temporal fusion transformer, TFT. Transformers are supposed to be a state-of-the-art in time series prediction. And we also use an ensemble, which just combined all the models' predictions using random forest. And we also used a baseline, which just carries forward the last observed blood glucose measurements. We felt that would be the most fair. For evaluation, we use mean absolute error as the primary metric, mean absolute percentage error, mean square error, and that's the secondary, and Clark error, which I explained earlier, is our clinical metric to see how actually safe it is in practice. So for cross-validation, we used a stratified patient-wise by number of measurements. So we made sure that one patient in one fold is not present in the other folds to measure generalizability. And we also made sure that they're stratified by the number of records, just because there are some statistical differences between a patient who has tons of records and a patient who has some. So for us, our best model turns out to be XGB. It's highly interpretable, it's a gray box model, and it's faster compared to deep learning. We suspect the reason deep learning, especially TFT, did not work is because there was not enough data. It typically requires enormous amounts of data to train. But XGB is probably better in practice anyway. And it works by combining the output of different trees. For those unfamiliar, is a very simple example. Let's say the patient's weight is over 80 kilos and the last blood glucose measurement was less than 10. It predicts 10 millimoles for the weight, 7 millimoles for the last measurement, first and second tree, and then it combines the output into 8.5 millimoles per liter. Typically, it would be a lot more trees, obviously, but a very simple example. For actual numerical results, XGB achieved 1.49 millimoles per liter, which is a 33% improvement over baseline, and the Clark error was 97.8. So this achieved outperformed the earlier works that I presented with shorter intervals. And for dysglycemia, however, hyperglycemia prediction is accurate, but there is still some room for improvement. Specifically, we achieved 2.15 millimoles per liter, 95.9% Clark error. However, for hypoglycemia, it was a 3.62 and a 0% Clark error. This is a massive drawback. However, we suspect that it was impossible for the model to predict it. There was no signal to predict because there was only 219 samples out of 37,000. So doctors are doing a great job, but that does mean that there's very little data for the model to go off of. And with more data incorporation, we do expect this to increase dramatically. This is the Clark error grid. A lot of endocrinologists would be familiar with it. So you want to be in zone A and B. The left here is baseline and the right is XGB. You can kind of hopefully see that it's squished towards the middle, which is what we want. For post hoc analysis, for missingness, we found that missingness was not random. It was not missing at random. And it was strongly influenced by clinical activity. So a patient that uses more insulin, has more hyperglycemia, has more volatile blood glucose, had lower missingness. A patient who had cancer, pericardial disease, had higher missingness, and a patient who was a transplant patient had lower missingness. So this seems to suggest that patients who are more volatile are monitored more often, as we would expect. And this means that missingness itself carries a clinical signal. Imputing missing not at random is quite difficult. We went with the simple weighted mean of the last measurement, blood glucose measurement, and the weighted average for that meal. This may create optimistic results because it is simple imputation. As you can see, as the percentage of missingness for each patient increases, the error decreases. However, this could also be a consequence of the fact that patients who are monitored more often are the patients who are already more unstable. So it's difficult to tell. What we did do is that we tried doing tipping point analysis, sensitivity analysis to see what if our imputation is wrong? How would that change the outcome? How would that change the model error? And we saw that even with the most aggressive shift, we would have to shift the imputation by over 2 millimoles per liter to get over a 20% increase in the error. So it does seem quite robust, regardless of the imputation method. And we also measured the error for the non-missing measurements, and it was 1.65 and 97.4. For the we also look at difficulty analysis, so who's difficult to predict and who's easy to predict. We found that patients who have high insulin activity, high glycemic variability, so standard deviation of over 3, a high hyperglycemia, acute illness and complex medication were all difficult to predict, again, as expected by physicians. And the one statistically significant feature for easy to predict patients is that they had tumor or cancer diagnosis. So we suspect those patients are easy to predict because they're more stable. This is a quick example of an easy versus difficult case. So this patient has a Clark error of 98.8%. The model does pretty well at following and it struggles right before surgery for the most part. The most important part is that the average blood glucose is 10.5, while the standard deviation was 2.89. So somewhat high, but the standard deviation is controlled. This patient, however, had a Clark error of 80%. And they had a myocardial infarction, so they're more unstable, it seems like. And they also had the most important part is that they had an average blood glucose of 12, but the standard deviation was 6. So a lot over 3. And the takeaway here is that it is not the average blood glucose, but it is the standard deviation, the instability of the blood glucose that makes it hard to predict for both physicians and the model. We also did SHAP analysis to figure out which features are most important. So most important features we found were blood glucose history. So here was we engineered some features. So the mean blood glucose over the last 24 hours was the most important feature, followed by the blood glucose value right before. And also blood glucose timing features. So which time of the day was the measurement taken, etc. And we found the model does very well with only those features with a mean absolute error of 1.5. So those features might be enough in practice if we were to deploy this. And that would actually be helpful from a data engineering perspective. So for future directions, let me just check the time. Okay, I'm quite early. So the study is the first of its kind to focus on hospitalized type 2 diabetes patients using routine electronic health records, specifically predicting capillary blood glucose and reflecting real-life conditions as well. It's methodologically robust, so we were able to handle irregular sampling. We performed a SHAP analysis that confirms blood glucose dynamics are the primary drivers of predictions. For limitations, it is a single center, single cohort study. The data set is relatively small. The data is retrospective. There's no nutrition information, so we don't actually know the mealtime, we don't know the actual mealtime, and we don't know what carbohydrates and such that was taken. So that would be very helpful if we were able to take input this data in the future. The model also had great difficulty with hypoglycemia, as noted. So where do we go from here? Hopefully in the future we can enhance data richness, so integrate meal timing and nutritional intake, which are currently missing. We can move towards higher resolution data in high-risk patients because patients who need to be monitored more often, they would have higher resolution anyway. We could also collect more data so the model can observe hypoglycemia. That would be the biggest help. And for validation, of course, we need to do multi-center studies across diverse populations. We do hope to extend this beyond type 2 diabetes and into type 1 especially, but it would need a lot more data to make sure that the model is able to generalize. And also, of course, across different electronic health record systems, so not just, Edmonton, not just Alberta. And it would be very helpful to have prospective trials. That is our goal, to compare how actually forecast augmented care versus standard care differs, if there's any difference, hopefully in a double arm study. And also, we hope to improve interpretability for each prediction. So for each prediction, we would like the physician to see, or the staff to see, why this forecast was made. And we can also try to advance the modeling, so building uncertainty awareness. So as well, this is also thinking of how it would work in real life, so that the physician can see how confident is the model in this prediction. If it's not very confident, the staff can feel more inclined to ignore that single prediction. And also forcing measurements away from the mean would be helpful because of the example I showed with the standard deviation. When the standard deviation is very high, it's difficult for the model to shift away from the mean very much. And using predictions as a foundation for the insulin predictor is our downstream goal. So in conclusion, we found blood glucose dynamics are the primary driver. Missingness itself carries informative signals. And hopefully this will be a foundation for real-time clinical decision supported insulin dosing and a template for scaling forecasting tools to a broader inpatient population. The next steps, we hope to do multi-center validation, prospective trials, and eventually bedside deployment. I'd like to thank my supervisor, Dr. Edelam, Dr. Vascarano, Dr. Jenfei Zhang, and the AHS, typed it wrong, AB Sporo, and Tara White for data access. That's it. Thank you.
Thank you, Lee, for the presentation. I'll pass it along to the adjudicators or the T-CAIREM team for questions, and then if there's any extra time, we will open up the floor for other attendees to ask questions. Thank you.
All right. Thanks, Leen. Also great presentation, very clear as well. One question I do have on the technical approach, you had a slide that showed a look back window, and you talked through there's a window with looking at 4 points, yes, and then you look at 5 measurements. So is this a dynamic look back window? Because you're using you looked at both a deep learning approach, which can handle dynamic window, and then you also have like a more traditional XG boost.
Yep.
So can you talk about how you're using the look back window for those different model architectures?
Yeah, so you're right. The deep learning can handle dynamic, but for tabular data for XG boost, that might not be the smartest approach, but we just would have 0 for, let's say, blood glucose lagged by 12, and if that's not available. So that is what we did for the tabular. So there was, at the beginning of the prediction, there would be a lot of zeros, but the model does seem to be handling it well. But yeah, that is what we're doing.
And what's the maximum window size that you would have then?
I believe it's 6 days, so 24.
24 measurements. Okay. Okay. And then you also had a slide that showed cross-validation, very briefly. And you talked about it was like 5-fold cross-validation, and you mentioned stratification. So am I correct? Did you stratify each of the folds to have an equal number of these 5 groups at the top, or are the folds and groups the same in the sense that, like, fold one has all of the people with 4 to 10 records.
No, the first one what you said is right. So fold
Okay.
one would have an equal number from
Gotcha.
group 1 to group 5.
Okay,
Yeah.
cool. And out of curiosity, how did you come up with these stratified levels? Was this based on data distribution or some sort of practice that you're familiar with?
We did notice that the patients who had a lot more records, like some of their features would be different. Some of the top of them, from what I remember, I think their medications were different. And also we noticed that I just was trying to stratify. We didn't have time. I noticed that some people did time to prevent like data drift. What we did have is record number, and we did notice that it also gave us better performance. So different data distribution slightly for different records and better performance was why we did it.
Okay. Next question I have, the Clark error, I'm roughly familiar with Clark error. I've seen it before, at least I've seen the diagrams. The Clark error for the baseline is surprisingly good. You do obviously improve upon it, but it wasn't a big difference. You showed some bigger differences when you broke it down into the different glycemic stages, but can you talk about the implications of this a bit?
Yeah, the baseline we picked for ourselves is difficult to improve upon, right? Because you're saying if this patient's breakfast was high, yeah, their lunch is also probably going to be tending towards high. So yeah, you're right in that the baseline is difficult to improve upon. It's already 93%. But like for reference, when creating like blood glucose CGMs, for example, they aim for a Clark error of 99%. So you need to be as high as possible. So it may not seem like that much, but within Clark error, that improvement is quite high, and we do actually aim for higher, hopefully 98, maybe 99 if we get more data. So yeah,
Okay. No,
that's
that's basically what I was looking for.
Yep.
My last question, at least for now, is that so I believe based on your answer to the cross validation thing, all of the data is split so that any given individual's data is either in train or test, which makes a lot of sense. It shows generalizability. Have you or your team thought about any sort of personalization? Like actually, my own research group has looked a little bit at continuous glucose and how it trends with the menstrual cycle, and you could see some very interesting trends for different individuals based on
Right.
menstrual patterns, and even outside menstruation, different patterns in how an individual's glucose varies. So is that something that you've thought about, or are you really keen on doing a something that generalizes to unseen users?
We have thought about it. From the beginning, we were set up to do generalizability because I think there actually is more research on personalization because it uses CGM. It's much more easy to do personalization when you have such vast amounts of data. However, when the patient's only in the hospital for like the median of 8 days, it is more difficult to do personalization, and we were hoping it would make more sense for a physician. Like this model, it works from the get-go. Like it will take in this person's measurements and their features, but it doesn't need sometimes a lengthy personalization. But we would.
I assume her video cut out for other people.
Yes.
Nope.
Yeah, sorry,
Hi.
I cut out. Sorry.
Yeah, okay. We only missed like 15 seconds of what you're saying.
Okay, sounds good.
I think I got the answer is that because of the
Okay.
setting that you're looking at, that there's, you having something that works from the get-go would be great. Yes, using rich CGM data would have advantages for personalization down the road, but the particular setting kind of demands something that's generalizable.
Yeah, that's exactly it.
Okay,
Thank you.
cool. Thank you. That's I think all my questions for now. Yeah.
Thank you.
Thank you, Alex. We will open up the floor for any questions from the audience. Yes, Gemma.
I have
Gemma,
a quick
You're
question.
muted. Oh, there we go.
You can hear me?
yeah.
Mhm.
Perfect. So I thought it was really interesting what you said about the errors being with respect to individuals who had tumors, I think.
Mhm.
That's what you mentioned. But
Yeah.
there's a
They-
lot of literature on how tumors change like your your metabolic profile. Especially often
Mhm.
tumors are very like hungry. So I'm not surprised actually that the model had
Right.
errors with those patients. And so I'm not so sure that's like a limitation of your model, as it seems more to me that it's actually like captured like true trends and patterns in the general diabetic population. I mean, it would be a disclaimer, like careful using this model with a patient with a tumor, but
Mhm. Yeah, thank you. I don't have medical background, so that was very interesting. I did not know that tumors shift the metabolism of the patient. I did not know that. But sorry, was that your question or your point?
yeah, it wasn't really a question. It was more just a point because
Yeah.
you framed error analysis, and I thought, oh, that's actually quite interesting medically because it seems less to me an error and more of your model has truly picked up on like general patterns in glucose use and something to consider
Right.
when framing this.
Sorry, I don't know if it cut out for me only.
I think they're not cut off.
Okay, okay. Sorry, you cut out a little at the end, but I think I got
Oh,
your point. Thank you for your
sorry about
point.
that, but hopefully you've got the gist of it and happy to
I
follow up
did, yeah.
after if you need.
Thank you.
Thank you, Gemma. I just want to check in with the audience if there's any other questions. If not, I had maybe just a quick question or just I might have missed this, but for the XG Boost model, you got this window of blood glucose observations. I was wondering, for example, were you calculating these some sort of summary features? I might have missed that point in the talk.
Oh,
That we
like
kind, for example, the
the
standard
engineered
deviation,
features?
yeah, the feature
Yeah,
engineering within those
here's an
windows.
example of the features, the engineered ones we use. Those were the most helpful actually. So the mean blood glucose over the last 24 hours. Obviously we use the windows as well, but the minimum blood glucose over the last 24 hours,
Mhm.
the minimum blood glucose, yeah, this is again. We also had the max, we also had the standard deviation, and we also had I think the mean blood glucose for that specific meal that we're predicting on. So those are the most helpful features. And of course we made sure that there's no leakage.
Perfect. Thank you. Very good feature
Thank you.
engineering.
Yeah.
I'll check in with
Great.
the audience. Is there any last questions? Last chance to ask a question. Going once, going twice. All right. Thank you both Marco and Lean for your presentations today. And thank you as well to our adjudicators and to everyone for attending. And wishing everybody a great afternoon.